Hi, this is Elliot Fishman, and let's start with part 5 on cystic pancreatic lesions. And let's take a look at cystic neuroendocrine tumors. Cystic neuroendocrine tumors are interesting. We typically think about neuroendocrine tumors as hypervascular masses, though also we sometimes see them when they're not very vascular, which can be a challenge. But they can also present as cystic lesions with rim enhancement, and those are the ones we're going to speak about. Cystic neuroendocrine tumors are often the result of the generation of a solid lesion, but smaller subtypes of cystic neuroendocrine tumors with their own anatomic pathology are also known and occur most commonly in the body and tail of the pancreas. And my experience is we see a lot of lesions in the tail, but they can be anywhere from head to body to tail. These are often associated with syndromes like MEA1, neurofibromatosis, or von Hippel-Lindau. Non-functioning neuroendocrine tumors are asymptomatic until they grow large enough to have mass effect. One of the things about neuroendocrine tumors, particularly the non-functioning ones, many people now say that if they're under 2 centimeters in size, to simply follow them. There was an article published in one of the main surgical journals just a week ago, as I record this, so that'll be in August 2024, that made the point that in academic centers, most patients with lesions non-functioning under 2 cm will be followed, while in private practice they'll be resected. And again, it's an interesting point, but with the frequency of neuroendocrine tumors in general being picked up more often because of CT and MR, we recognize that doing a distal pancreatectomy or any part of the pancreas resection may not be necessary, but the question is, what are the proper cutoffs and how do we do it? So typical things in terms of CT, it's a cystic lesion with a peripheral hypervascular halo. You can have liver mets, but most of the small ones do not have liver mets. You can have endocrinopathies, but it's rare in cystic lesions unless they're syndromic. And we mentioned that patients can have syndromes. MEN is one of the syndromes we think about. Cystic neuroendocrine tumors, and we wrote this article way back when, almost always demonstrate the presence of either a peripheral rind of hypervascular enhancing solid tissue, or alternatively hyperenhancing mural nodularity along the margins of the cyst. The diagnosis is one of the primary reasons for the inclusion of arterial phase imaging in the evaluation of suspected pancreatic cystic lesions. And that's a good point to make, because remember before we mentioned how the venous phase imaging may be more valuable. One finding arterial phase works well in cystic lesions also is when we spoke about the rim of enhancement that happens as vessels are stretched with serous cystadenoma. In this article by Rahman, we mentioned that given that hypervascular components may be less conspicuous on venous phase, these lesions are not infrequently incorrectly diagnosed as IPMNs when only a venous phase is acquired. So again, something very important, going back to the first talk about the importance of protocols and how we do things to make sure we do things correctly. Now, the cystic lesions can vary in size. Here's a cystic 5 centimeter lesion, tail of pancreas, wall thickening, rim enhancement. Differential here, I'd be thinking about an MCN right away, but as you look more carefully, there's more enhancement present. There's calcification in the rim, but remember, calcification can be seen in MCNs as well as neuroendocrine tumors. So this can be somewhat challenging. Thickened wall, if you had a high-grade dysplasia or carcinoma in an MCN, they can have a thickened nodular wall like this. So I think it's never always going to be so simple. This one, I would want to make sure we're not dealing with an MCN. But also the truth of the matter is, because of this lesion size, whether it's an MCN or it's going to be a neuroendocrine tumor that's cystic, they're both going to have distal pancreatectomies. And again, often the enhancing rim is best shown on the volume rendered images, nicely shown here, and really nicely shown here on the cinematic rendering as well. And here it is shown from the sagittal view, where the rim enhancement, the thickened wall, and the cystic components are all very nicely shown. Another example, cystic lesion, tail of pancreas. You look fast, you can think about IPMN and MCN and serous cystadenoma. When you look more carefully, and then you do some changes in the window width and center, you can see that there's rim enhancement. The rim enhancement says, okay, this is not an IPMN. Also, the fact there's no dilated pancreatic duct. Could this be an MCN? Yes, in theory, location, maybe patient age, but MCNs typically don't have that rim-like enhancement, and serous cystadenoma is very much the same story. This is enhancement. It's not a vessel draping. And as you go and you make more images, again, I really like the cinematic rendering and the volume rendering for really accentuating rim enhancement. And so you have a very good feel you're dealing with a cystic neuroendocrine tumor, and based on size, this will be resected. I showed you larger ones with thickened wall. Here's just a similar example, to identical almost to the case from a few moments ago. But again, thickened wall, nodularity, rim enhancement. Again, this was a neuroendocrine tumor, but thinking about an MCN is probably not the wrong thing as well. Cystic neuroendocrine tumors can be very large. Here's one in the head of the pancreas, large, cystic, rim enhancement, nodularity. There's some glandular atrophy more distally. This is not going to be a serous cystadenoma. It could be an MCN, I guess, but usually they're not so vascular and usually don't occur in the patient's head of the pancreas. So some solid components, cystic components. This was a neuroendocrine tumor, really nicely shown on the coronal views, where you see the cystic components as well as visualizing the patient's solid components as well. Now, I mentioned that, and I showed you before, some serous cystadenomas that are very vascular on our arterial phase imaging. Maybe on the venous you see a bit more of the septations. It can be a difficult diagnosis just looking at the imaging, distinguishing between the two. Venous washout may be helpful, as I mentioned, because the cystic components are better seen on venous phase imaging. And if you have vessel encasement, then it's usually a neuroendocrine tumor. If you have vessel draping, then typically it's going to be a serous cystadenoma with that vessel draping or stretching. So here's a nice example, pancreatic mass right near the head-body junction. Very vascular. Again, neuroendocrine tumor is a good thought. Metastasis if the patient had an absent kidney or had renal cell carcinoma. And this was a neuroendocrine tumor. There is some cystic component. There's no dilated duct. There probably looks like a second lesion. If you have two lesions, then either you're dealing with neuroendocrine tumors or metastasis. Mentioned Mets most commonly from renal cell carcinoma, very vascular. And here's the vessel where there looks like some draping of the vessel. So you might be pushed or at least think about a serous cystadenoma, but I don't think you really would be thinking about that. Surely with the second lesion present and its appearance, I'm sticking with neuroendocrine tumor over a serous cystadenoma. You can look at the washout. The lesion washes out. You see some cystic component centrally, but you're not seeing a large cystic component, and you're not seeing any more of the changes you might expect to see in a patient with a solid serous cystadenoma. But I don't know. It's kind of a tough case. Here it looks on the later phase more solid. Could there be some draping present? And this indeed was a serous cystadenoma. Here's another one. Again, I'd be thinking about a neuroendocrine tumor. Looks like two lobulated lesions, very vascular. To me, it looks all the world like a neuroendocrine tumor. That's what I'm thinking. There's no vascular invasion. Vessels are pushed, but you don't need to have vascular invasion. So it is really going to be a challenge. Again, think about serous cystadenoma. Those solid variants are very difficult. We are writing some articles about that. Hopefully we'll be able to publish them and show you what else we've figured out. Now, one of the last lesions we'll talk about are SPEN tumors, solid and papillary epithelial neoplasms. Usually it's a younger population, which makes the diagnosis easy. Teens to patients in their 20s. It's usually females by a ratio of 10:1. Clinical presentation can be vague abdominal pain. It's a benign lesion. When resected, the patient is typically cured, though about 10% of patients will develop recurrence or metastatic disease. long-term outcome with surgery is indeed very, very good. Now, the average size is 5 cm with a range of 1 to 10. It's typically a solid mass with cystic component. Again, can be confused with serous cystadenoma, can be confused with a cystic neuroendocrine tumor as two examples. Calcifications may be extensive, especially around the border of the lesion, with calcifications present in up to a third of lesions. And again, the lesions are a bit more common in the tail of the pancreas. But, we said MCNs and serous cystadenomas also live there as well. In this article by Miller about pancreatic cancer and its mimics, SPEN tumors are rare. Unlike PDAC, solid pseudopapillary neoplasms are younger women and show low malignant potential. They tend to be large at presentation, well-defined, and again, their appearance is classically different. With most SPEN tumors, you do not see dilated pancreatic ducts. And again, the age range is so helpful, though we are seeing younger patients with pancreatic cancer in their 30s. We've seen a number of those, but usually not in their teens or 20s. So it can be very helpful. SPENs are less commonly associated with pancreatic and biliary duct dilatation, upstream pancreatic atrophy or vascular invasion, but still biopsy is often necessary to make the diagnosis. Patient with abdominal pain, look at the pancreatic head. There's a low-density lesion well-defined. I don't see a common duct or a pancreatic duct dilated. This is an 11-year-old female. Okay, if patient was younger, I would say pancreaticoblastoma, which are typically vascular, and they occur in patients under age 5. So when you talk about an 11-year-old pancreas, you can get a pseudocyst from pancreatitis, I guess, depending on the history, including trauma. You could get a pancreaticoblastoma, and you can get a SPEN tumor. There it is, very nicely shown, well-defined, well-marginated, cystic and solid. The vessels, portal vein, and SMV. You can see the well-defined margins of the patient's lesion on the cinematic rendering, both through its various perspectives. And again, with the 11-year-old cystic lesion, you got to see a SPEN tumor. Patient had a Whipple's procedure. This was a SPEN tumor. The patient hopefully is cured. Another patient, 31-year-old female. This is trickier. It's body of pancreas. Could this be a carcinoma? Yes, but I would see dilated pancreatic duct. Here we don't see a pancreatic duct dilated. Could this be an MCN? The age is not bad. It's a little bit young, but it could be. You would have to sample this lesion, which was done, and this lesion ended up being a SPEN tumor in a 31-year-old female. So again, variable appearance across the age groups. Another lesion, cystic and solid, central dense calcification. That description always makes you think of a serous cystadenoma, but look how good this was. Look how sharply marginated. And this was a 33-year-old female, so it would not be bad for a serous cystadenoma. Not great for MCN patients. The lesion has that central calcification, but when I see central calcifications, I'm always thinking about serous cystadenoma. Though typically I talk about speculated calcifications or spiculated calcifications, not this big clump of calcium. You can see some stretching of the vessels here, a good size mass, shown nicely in arterial and venous mapping. And this indeed was a SPEN tumor. So you can see SPEN tumors have a range of appearances. Here's another one, cystic lesion, thickened wall, head of pancreas, where the septations on the MIP imaging show fairly significant calcification, thin septations, but the calcification is one of the most impressive things about this lesion. Now again, I showed you way back when a pseudocyst which had calcified. We spoke a little bit about MCNs calcifying, but typically not a rim calcification. We talked about serous cystadenomas calcifying, but not circumferential like this. So when you see that, you got to really be thinking about a SPEN tumor. And here it is nicely shown again when you go from the volume rendering to the MIP imaging, which really accentuates the extent of the calcification present. Another patient, here's a solid lesion, no dilated pancreatic duct in the body and tail of the pancreas. It doesn't really look like an MCN, but location would be great, and it could be. It's not cystic enough for a typical serous cyst adenoma, and it's not vascular enough for a vascular serous cyst adenoma. So what could this be? Could it be a neuroendocrine tumor, an unusual neuroendocrine tumor? There's no dilated ducts here. It's sharply marginated, well-defined. What am I dealing with? It's kind of a tricky case. You know it's going to be biopsied, and you know it's going to be resected, but this was a SPEN tumor. So again, SPEN tumors, we talk about cystic, we talk about cystic and solid components, but this case is more like it's homogeneous solid. It's no vasculature, there's no dilated duct, just an unusual appearance for a SPEN tumor. And here's another one which looks a bit more cystic, coming off the tail of the pancreas. Again, MCN consideration, serous cyst adenoma. There it is, like a lobular lesion coming off the tail, and this was a SPEN tumor, very nicely shown on the volume rendered views, some of the components within the lesion. But again, a very, very challenging case. Or this one, again, peripheral enhancement. Could it be an old hematoma, pseudocyst? Can it be a neuroendocrine tumor? They calcify all sorts of ways. We talk about MCN with rim-like calcification. And here, when you look at the coarse calcification, some higher density within the lesion, gives you the feeling that this lesion must have bled at some point, and maybe that was the reason for presentation. When you look at the MIP imaging, you really appreciate the coarse calcification. So what are you dealing with? It doesn't really look like serous cyst adenoma, doesn't really look like an MCN, but I couldn't exclude that. Neuroendocrine tumors can be cystic with rim-like calcification, though it's usually more vascular, as we showed a few moments ago. So what do you do with this lesion? These are the ones that really drive you crazy. You can give a differential, but you're not really betting on any one thing. You're waiting for the path report. And this was a SPEN as well. And another SPEN could be this one, where it's a solid mass, big and solid. This one was cystic, some solid component with lots of calcification. This one has minimal calcification. It's mainly solid. You can see there's some lower density zones on the volume rendering and on the cinematic rendering. And on the cinematic, you can see some areas of necrosis centrally, but it's really a challenge. Or this case, cystic lesion tail of pancreas. I got to go in a 66-year-old male with a non-functioning neuroendocrine tumor. I guess it could be a, I don't know, could it be a MCN, serous cyst adenoma? But the age, I would surely think about a neuroendocrine tumor, and this ended up being a SPEN tumor. Remember I mentioned the average age is teenage to 20s. We showed you some age 11, and now we're showing you a male in the late 60s. So again, calcification can be a great sign for helping you in the differential diagnosis, but it's not always going to bring you home to the right answer. So it can be challenging, and very nicely shown here as well, really showing you a good look at the cystic lesion. We published an article on cinematic rendering talking about that SPEN tumors are a rare subset of pancreatic neoplasms. We talk about cinematic rendering can be helpful in showing the cystic and solid components of the lesion. We talk about the calcifications being present in about a third of cases. But again, the appearance, as I showed you, of calcifications from being very coarse to being very thin, from being in the periphery more than in the central regions. While most SPEN tumors present with these imaging findings, atypical presentations can make the diagnosis very challenging, which is indeed the case. And as we've gone through, the differential diagnosis for these tumors will vary from neuroendocrine tumors to PDAC to serous cyst adenoma to MCN to metastasis. So again, it can be very tricky. You have to really understand what you're looking at, look at some of the features, the age, the history, but it can be a very difficult diagnosis. And one of the reasons I put together this talk on pancreatic cystic lesions is because everyone at times seems to think, oh, we got all the answers. Well, I'm telling you, we don't have all the answers because there's lots of variability. And again, this can be very, very nicely shown with things like cinematic rendering, which can be helpful, but a lot of work still needs to be done if we're going to reach the correct answer in the majority of cases. Now, there are a few other things I wanted to speak about, and I think we're kind of out of time. I also want to talk about where I see future directions in the evaluation of cystic pancreatic lesions going. So let's stop here, and let's pick up next time with lymphoepithelial cysts, and that'll be part 6 of 6. See you soon. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.